Theresa today. As you all know, she's a family nurse practitioner. She's the Chief Quality Officer for Penobscot Community Health Center, and I've had the pleasure of co-presenting with Theresa on HPV and other things at different occasions. So looking forward to doing this today. And you all know me as well. So I would like to, at this point, just the next slide, please, and we'll start with the didactic. So Anna, I love your slide, and I've asked you if I can use it, but I think it's a great point for us to always go back to, because as faculty, when we develop this didactic schedule, really looking at all the evidence-based interventions and talking with you all about these different options that you have, these are the way we know, right, if these are implemented, and the more the better, right, best done in combination, like it says here, the more successful you're going to be in increasing your HPV vaccination rates. So if you look down on the list, we're going to be today talking about, reducing barriers and increasing access. So that's the evidence-based intervention that we're going to be talking about today on this didactic portion. Next slide, please. So at this point, I'm going to turn this over to Theresa. She's going to be talking to you all and taking a deep dive around increasing access to vaccinations, and also looking at standing orders is another way to do that. Then I'll be talking about scheduling that second dose, that 6-month second dose HPV appointment at checkout, and then some workflows when that is not done that you can use for outreach. And then again, talking about starting at age 9, that's another way we can reduce the barrier, and talk a little bit about some evidence that supports that. So Theresa, I'm going to turn it over to you.
Sure. Thanks, Jess. So in preparation for the presentation today, I did a bunch of research, including, a lot of the CDC information out there, and there's lots of sort of vaccine sites where they talk about best practices and sort of reference specific studies. So I sort of tried to accumulate as much as I could from what was out there, and based on what we've done here at PCHC, and that I've seen some of our peers across the Northeast do with some success. So not one of these will work for everyone. And sometimes, I know at least here at PCHC, we've had to implement 2 or 3 of these, sort of like a shotgun approach, hoping that we're going to access and sort of target more of our patient population. So here are just a bunch of examples of things you can do. So the most sort of standard thing that I think everyone can do in their practice is allowing sort of patients to walk in without an appointment during office hours for vaccine only. So some of the barriers we put up are requiring them to call, having an appointment. They might have to sit for a period of time. And so allowing them to do it when they've got, free access, or where they're thinking about it, or where they're, waiting for something else, they can sort of drop in and get these done is helpful. So the other part to think about is expanding your opportunities to immunize by extending office hours. It doesn't have to be every day, but I know here at PCHC, we have walk-in care hours for our peds practice, as well as some of our adult practices. We have weekends and nights, and so we do allow people to hop in or pop in and get immunizations if needed. And so providing, I know one of our Belfast practices will have some evening hours, and so patients can come in if it's more appropriate for them and bring their families to get immunized. So at least here we have a significant population of individuals who have 2 working parents. And so, trying to get to the clinic prior to 5 p.m. During the work week can be really challenging. So we try to think about ways in which we can offer more access to them. The other thing to push is making vaccinations available during visits for minor illnesses. So we do vaccinate during walk-in. We do vaccinate during sick visits, as long as it's considered a minor illness. So, ear infections, upper respiratory infection, things like that, we are encouraging vaccination. Nurse only or medical assistant schedules is another thing we've implemented, and I've seen other practices, other health centers adopt with pretty good success. So same sort of thing, you can either schedule them on that MA schedule or nurse only schedule, or again, when they walk in, put them on that schedule so they don't have to necessarily see a provider in order to get immunized. For those people who miss visits and they can't be rescheduled quickly, you can, again, reschedule them for just the MA or the nurse visit only. So if they had a scheduled well child and you've got a provider who might have left the practice or a provider who's going to be on extended leave, instead of pushing that well child out and those immunizations out, you can have them come in just for the immunizations and then have them do the well child when the provider's available. Talked a little bit about walk-in care settings already. I know some areas have local health departments and they offer immunization clinics. And so they oftentimes will get free immunizations like we do from the state. And so if it's more suitable for them to pop in there to get those, that's another option for people if it's closer to where they live and more access. Other studies I saw, they'll vaccinate siblings, even if it's not their appointment. So if you've got a child coming in to get their immunization, if the other siblings with them are not up to date, actually vaccinating them at the same time. That was not something I had thought about. So that's something we're going to talk about here at PCHC. And then immunization only clinics, or vaccine clinics, if you've seen those. Oftentimes people do that for flu. There's lots of success around just holding days or even a few hours a day, a month, where you advertise and people know they can drop in, and you can run the impact report, identify what they're sort of due for, and get them up to speed. Those are pretty successful. And I know we do those here for flu clinics, and we're thinking about maybe doing those for adolescent vaccines as well. Next slide. The other sort of thing to think about when you're trying to talk about increasing access to vaccines is sort of going where children are, right? So the way our medical model is set up most of the time is we expect them to come to us, and that works for a big part of our population. But there's a subset, like I mentioned, of population where that can be really challenging. So sort of thinking outside the box of other ways or other locations where children are, that you can go to them. So if you've got school-based health centers near you, that can be a good opportunity for them to help immunize your kids if they're having a hard time getting to your clinic. So you can reach out to the state, and they have a listing across the state of those school-based health centers. Even if you don't have sort of a well-defined school-based health center, you can actually reach out to local schools and offer to go into the schools and vaccinate kids. Sort of have a consent form, and then get kids up to speed. Again, public health departments will hold clinics as well, and so maybe reaching out to your local public health department and seeing if that's something you can coordinate with them. WIC program offices sometimes will do that, and you can offer to go there for some of your kids or even some of the kids in the community and do vaccination clinics. In a previous setting where I worked, we would go to child care centers and actually vaccinate kids there, suggesting local pharmacies. Pharmacists now in the state of Maine can administer, and so that can be another option for folks who might have a hard time getting into our office. And then just one thing I wanted to talk about specifically was the Rhode Island model. So I'm not sure how familiar you all are with that, but the Rhode Island model actually has a contract at the state level for an organization to go into all of the schools and actually administer all vaccines. So 5 to 19, they're immunizing. And so that model, you can see here, they increased their rates for, at that time, all 3 doses of the HPV vaccine were pretty dramatic at 76%. Because it was just easy access. Parents didn't have to think about it. They didn't have to take kids out of school. They didn't have to set up appointments. They didn't have to, find transportation. So they went in the state of Rhode Island to where the kids were and actually had a very, very good immunization rate across the board for all vaccines. And this was just one of those. Next slide. So talking a little bit about standing orders. This, I will say, has been probably the single most effective intervention we've done across the board for all of our quality improvement here at PCHC, and HPV is no different. So sort of allowing delegation to other members of the team to do some of this work and take the burden off the providers really has been impactful. And so Standing orders are basically protocols. You have either your lead physician or any of your other physicians who dictate what other staff can do without direct involvement from them. So they don't have to actually do the order. You don't actually have to go and get permission. And so our staff here pull up the impact report, identify what they're due for, and will administer the vaccines before the provider gets into the room. And that's been helpful. So here you'll see a couple of websites that I put in here with potential templates that you can sort of steal and borrow, and then just screenshots of what those sort of look like. Next slide. And then another website where sort of, you know, as you get the standing order, how you sort of implement those. And I would say try to pick something to start with if you're not doing these currently in your practice. Pick something that no one would argue about. So it could be the first dose, say, if you want to sort of tread lightly and jump in slowly. And then if you are using the EMR, consider whether you can put the standing orders in as prompts within the system, so it's not on paper in a sort of a separate system. And then there are some screening checklists. So some providers are very worried that the MAs or the nurses or whoever they're delegating to aren't going to necessarily think about all the contraindications. So there's an actual checklist here for HPV specifically that allows staff to kind of run through that list of the things to think about. Next slide. And that's, I think it's Jess's turn.
Great. Thank you so much, Theresa. So I'm going to just highlight a couple of points, looking at keeping time in factor, so we have time for Marie to go through her piece with all of you as well. So again, one thing I want to point out is focusing specifically on scheduling the second HPV 6-month HPV dose at the current visit. So when they get that first vaccine, this is a critical time, and I've had a lot of practices have some great success just focusing on this alone. So this is a PDSA cycle that they will implement, and they will say, okay, this is what we're going to focus on. And there's a couple of different ways that we're going to do that. So having a workflow around scheduling this 6-month dose, and I'm going to show you that in a minute. And then also having a workflow for outreach and follow-up when the parent leaves without making this appointment. So again, making sure you're capturing the fact that they did not make that appointment and following up with them. So next slide, please. So this is a workflow that I've developed, really looking at this entire, you can really break this apart, right? So you've got pre-visit planning and you've got your HPV vaccination workflow. And the way this kind of all flows together, it really made sense instead of making two different workflows to really combine it. So just quickly, again, I'm going to go through this kind of quickly for time, but you're going to get all these slides. Looking at the pre-visit planning, some start the day before, some start the morning of. The MA is pulling either, for their provider schedule, they're looking at the immunizations that are due and either have that ready to go or for the next day, or then we'll roll into that. If it's the same day of the appointment, they have that morning huddle with the provider, the patient comes, they don't come, right? That's another whole workflow to follow up with them, but they come up. And again, this may be a little different based on your practice, right? And what's nice is I'm going to send these out to you all electronically, because this PowerPoint is really easy to work with, and you can use this for all kinds of things. So once you've got this template, it's really easy to make it and use it for anything that you want to use it for. So again, looking at this flow of triaging the patients, talking to them, yes, they say to the vaccine. Again, they can enter the order, like Theresa said, if you have standing orders, they can give the vaccine. And then this is where I want to point out for this presentation, where it says PDSA cycle. So at some point after that MA, again, whether it's a provider, you can see the other components of that, where the provider discusses, they say no to the vaccine for the, MA. Oh, that's helpful. Thank you, Annie. And then it rolls into the provider discussions. You can see it all comes to that same point, right? And so they've said yes, they've gotten that first dose. And what type of reminder? That parent may have 2 or 3 kids, the adolescent may be a little upset because of these shots, they're trying to get out the door. What are you giving them to remind them or do or give at checkout to schedule that 6-month second dose appointment? And if you don't do anything, that's something to think about. And I can actually get you some examples. I've had practices actually make up some cards And I'm happy to share those. So please let me know if you'd like one. And basically, it's not just for HPV, right? It's so if they need an asthma check or they need, something else, it's, the provider takes that, they check it off, or the MA checks it off, and they hand it at the front desk. And then the PSRs find that very helpful, and they can schedule that before they leave. So next slide, please. This is a little simpler. So this is now they've left, right? So even though you gave them the reminder, you've done all that pre-visit planning, you've got everything ready to go. And I didn't take a deep dive into prompts. We've already covered that with all of you for the provider and what those look like. And so now they've had their appointment, they've gotten that HPV dose, yes, and now they've left and they didn't make that appointment. So again, making sure that if they're leaving and not making that 6-month appointment, that you're following up on that and tracking that, so that you can then do whatever outreach that looks like. This practice, they do 2 calls to that list. If there's no response, they send an educational letter specific to HPV. You all got that in the beginning of this project, and then you track that and continue outreach. So that's that component. And then again, just for sake of time, I'm going to, thank you, Annie. Yes, thank you so much.
Okay.
Yeah, perfect. Thank you. So starting HPV vaccinations. So looking at 9 years of age, we've talked about this. Thank you, Anna, for sharing these fantastic resources. So this is looking at a study by Jennifer St. Sever and the Mayo Clinic and other researchers showing that starting the HPV vaccine series, starting the HPV vaccine series at age 9 or 10, they were 22 times more likely to complete the 2-dose series by age 15 than those who initiated the series at 11 or 12. So this is incredibly impactful, and there's a link to this. And for sake of time, I'm just going to touch on this briefly. So next slide, please. This is another slide. The link doesn't seem to be working super great, but we're going to send you the actual article. Again, thank you, Anna, for the American Academy of Pediatrics and why they're recommending now vaccinating as early as age 9. And the takeaway for that is the ACIP recommends around 11 and 12. And the AAP is saying, you know what, we really need to take advantage and really need to do this at age 9. So I'm just going to wrap up. This is another social media graphics that Anna had shared. Really back in when we were talking about this, you're going to get this. But again, the HPV vaccine is older than the first official iPhone, the Kindle, Twitter, just some really cool talking points to be able to say when parents say, you know what, it's really new. Well, actually, it's really not that new. So I'm just going to wrap that up real quick now for sake of time and go into, so again, I'm sorry to go through that kind of quickly, but again, I want to give Marie time to be able to talk. So Marie, we're going to turn this over to you. So I'm going to turn this also over to Danielle a little bit so she can just tell you how to minimize the Zoom so that you can pull up impact where you are. And Marie can kind of talk you through how to pull the AFIX reports. Marie.
All right. So has everyone had a chance to bring up their impact and minimize?
If your Zoom is in full screen, you can go to the top of the window and exit full screen, and that will allow you to keep the Zoom window open, but also navigate to other things on your computer, such as impact. And if anyone's having trouble, you can feel free to chat me, and I'm happy to help you directly and let Marie continue to speak.
All right, perfect. So once you're logging into Impact, on your left-hand dark green toolbar, under the Reports section, they're down a little more than halfway. I'll link the AFIX product. And if you all were to click on the AFIX product, it's going to bring you into another screen. I feel like I had to sign up or do something when I first got in this, although it's bringing me to that right now. So if any of you are having trouble getting in here, you may have to fill out a little something. I'm not quite sure. If you are in the AFIX products page now, again, on your left toolbar, you'll see a couple of buttons, your AFIX cohort and flexible cohort. I've found that the flexible cohort is where you can kind of customize the reports how you want them to be, rather than doing a grouping of vaccines, say for 2-year-olds or the entire adolescent vaccines. So if you were to click on the flexible cohort, you're going to get another window that pops up.
and you are able to then start choosing what you want for parameters. I always leave the as of date. It's already got the little pre-populated dot on there for you. And then you're able to start choosing your birthday ranges, the ages that you want to go into and run those reports for. I don't put anything into the as of birthday field. I go right down to the age range. So the age range, you can obviously do your 10 to 11-year-olds, your 11 to 12-year-olds. Your 12 to 13-year-olds are probably the easiest reports to run, and I'll show you why in just a moment. If you put in your age range from, and you put your 12, and then you're through 13, and then another little pop-up window is going to come down where you're able to choose either months or years. So obviously we're choosing the years. Your next little section with the drop-down menu is your vaccine group selection. So we're going to choose our HPV vaccine. Right beside it to the right, dose count has a little drop-down menu there. And so it gives you the option 1 through 6 or up to date. So on my 12 and 13-year-olds, I guess that if I were running the report and wanting to look who's overdue, I would choose perhaps the 1, because I want to see anybody from the age 12 to 13 who only has 1 dose of HPV vaccine. So if we chose the 1 there, you're going to notice a little plus sign right beside the dose count where we just chose 1. I'm going to have you click on that plus sign button. And that's just saying that we chose the vaccine group HPV dose count of 1. It's sort of verifying that. You do have the option, you can see a little pencil there that you could edit it if you decided that that wasn't really what you wanted to do after all. But let's go with HPV and dose count of 1. It automatically puts in the birth date ranges for you, which is fantastic. I hate trying to figure out my birth date ranges. Underneath that, you're now able to choose the reports that you want to run from the criteria that you just entered. I found that choosing more than one of these criteria really slows down your report time. I like to choose just 1. In this case, I want to choose the patient listing. I want this report to show me the list of patient names of children 12 to 13 who have only had 1 HPV dose. So if you click on the patient listing button, and now you choose at the very bottom right-hand corner your submit button. It kind of brings you back up to the top of your report, and in like little small font, green font, success, the following job is successfully added to the scheduler for job ID. And it will actually give you a job ID number. If I've run more than 1 report, I tend to jot that number down because it will give you a list of reports that you've run. So at this point, I will tell you that these reports do run really, really super slow. What I have done is I've actually logged out of the AFIX tab altogether, give it 10 minutes, work on something else, and when I log back into the AFIX report, again, on your left toolbar, very left side, you're going to see list of scheduled jobs. And if you click on that, it's now going to bring you to that job that we just did and the job ID number. It may still right now, mine still says in progress. Like I said, it sometimes takes 5 to 10 minutes for these reports to be done, and even longer for one of my bigger sites that has lots and lots of children, perhaps in that age range. But if you did give it that 5 to 10 minute window, come back in, click on your job ID number, which is kind of highlighted in a light blue font. Once you click on that ID, it's going to bring you right to your report and give you your patient listing of your 12 to 13-year-olds that have only had one HPV. So that's pretty much how you run the reports in AFIX. I really played around with it to figure out what I wanted to set for my parameters. My toughest one, I would say, was my 10 to 11-year-old age group, because it only gave you the option of choosing, 1 through 6. Well, I want my children that haven't had any HPV vaccines at all. So that was my most challenging, and I guess I haven't really found a way, honestly, to do that other than running my regular report and impact of my patients that are overdue in that range. So if anybody has some ideas or has had any luck running these AFIX report, certainly chime in and let me know, because I haven't been able to find that one. No. Theresa just asked me about the pencil and being able to edit that. Again, it doesn't give you the option of choosing 0 vaccines. It's 1 through 6. So like I said, I haven't been successful in getting those 11 to 12-year-olds with no HPV vaccines whatsoever.
Great, thank you, Marie. So I'm just going to pause